All right. Hello, Arizona. It's the first time out here. Thank you very much for having me out here. It's taking us nearly a year to get here.
Yeah, that's right.
So to give you a little background how that started, my wife and while we were in masterminds and they're working on learning how to do best practices in the gym, what's better for the clients, and then it came up about what we do with our other business. I'll tell you how we got there here. And he told me that there was very few providers out here that are actually doing this type of stuff, right? And then as I researched it, there's very few providers in Arizona, period, right? So they have a hard time getting people to practice out here, to the fact that your legislation just passed legislation to fast track licensure for providers in the state of Arizona to 5 days. That wasn't my case, but I guess in the future they're going to try to get more. So you're going to probably see many more people coming in via, the telemedicine route like I'm doing, right? So the first thing that I will tell you before I get into everything else, I am not here to sell you anything today. Nothing. This is the way I practice. I don't believe that when you get into the healthcare, it should be a used car lot. There's no impulse buying. It's nothing you should really do. Anything that I tell you that I go through right now is all about education. My purpose here today is to answer your questions, educate you about andropause for men, perimenopause for women, menopause, and that transition. What does that look like? And what do we do now to go ahead and help you live a more fulfilled life, right? And that's basically on the guidelines from the Menopause Society itself, right? That's everything that I do. I've been to their conferences. I had an abstract last year. In fact, my abstract in the Menopause Society last year was the only one on testosterone, believe it or not. So we're still a little bit behind the game on women's testosterone. A little bit about myself, and I'll keep it short because I'll tell you what I do a little bit and where I'm coming from and how that helps me with practice, right? It's not about me and what I did and all the accolades that I've been doing in all my life and all my accomplishments. It's about my life experience and how does that relate to you, right? Because if I can't understand what a beginner goes through and haven't done it myself, then how can I help you get through that process? And two, if you're a high-end athlete and you get to that thing, how am I supposed to know how you feel or how you're going to recover or what you need at that particular point if I don't function that way myself, right? Or I haven't functioned that way. So from A to Z, that's how I think it helps me become a better provider. Secondly, the cool thing that's really helped for me is artificial intelligence. AI it now kind of writes my note, right? So it will listen and it will write my note. So why is that so important for me? Because when I sit down with you and I talk about you, I can really talk about you. I don't have to think about taking notes. I don't have to think about what did I write. I don't have to do things. I can really focus on you, your journey, your goals, what you're doing, and then I can educate you without worrying about the note. When the note comes up, I just edit some of the things that I remember and off it goes, and then we go from there. So it's really cool the way we're going in medicine and health and everything else. Secondly, AI is really good for you, all right? Now, it depends on what you put in. What you put in is what you get out, right? But what I tell everybody when I educate you and I go through and I come up with a plan, don't believe me, this is a collaborative relationship. This is a two-way street. So if I tell you to go look something up, go look it up, right? Call me on it, right? Make sure that you know that what we're doing is that's the standard of care. So a little about me. I joined the military at 17 years of age. I was in the 82nd Airborne Division. I was an Army paratrooper, Black Hawk helicopter crew chief. Got out of service, thought I was, went back to Massachusetts, thought I was going to be a police officer, went to Florida, moved down to Florida to be a police officer, quickly found out I didn't want to do that, became a firefighter, right? Got my paramedic license in 1988, got on the fire department in 1988. 1992, we thought we were going to go to medical school, right? We're doing all this cool stuff in the field, right? We're innovating, saving people's lives, doing all this stuff. Let's go become a doctor. We didn't have whiteboards. We went on the blackboard, we did the math, we had mortgages, we're not going to do that, right? That's too much time, effort, whatever. So we found out that the nurses were making more money per hour than we can make overtime in the trucks. And that's when it was passé for males to go into nurses, but we're firemen, we don't care about that, right? So next semester, 15 guys showed up. That eventually turned into long-term down the road. As I got promoted, to captain. I was captain for most of my career in the fire department. I was on the dive team for 20 years. I went through a lot of training with the Navy SEALs down there, the military trains in the Keys. And then I became the infection control officer for the fire department. We're the 5th largest fire department in the United States, the 2nd largest geographical territory next to LA County. We're a very big department, we have all the big toys, all the big bells and whistles. There's a lot of opportunity for us. We came up with a comprehensive plan for exposures, that if you're exposed to HIV, we could drop the antivirals into our patients within 1 hour, our firefighters within 1 hour, because we do rapid testing in the field. We were the first ones to ever do that. We got a national award. We went to Washington, D.C., and Vice President Biden gave us the award. It was very cool to go up there and do that. That turned in later on, somebody said, hey, why don't you go to MP school? Well, at 49 years old, I needed to go to medical school like a hole in the head, but a God-fearing man, I applied to UM and I got in, right? So most of my clinicals were done in Haiti. I did it in a rural environment down in Haiti. I'm a family nurse practitioner, and no electricity, no running water, nothing out there. We drove in trucks and everything else with all our gear for 3 hours up in the mountains to go see people. It was very, very cool, very humbling, right? It really got your skills much better, because now you had to go ahead and not only speak to people that didn't speak your language through a translator, you only had to use your hands and your knowledge to figure out what's wrong with these people. It was really good education for us. Then I went into vascular surgery. So I got out of that, and I was about to retire from the fire department, and I went into vascular surgery. Vascular surgery works on every vessel inside the body except for the heart and anything above the jaw. Carotid arteries, main arteries, everything, bypasses, amputations, lower legs. I worked for 5 years learning the craft, and then these guys saw me making stuff at home. Like, I build a lot of stuff. I'm very good with my hands and all that stuff. I'm handy. I said, hey man, you might be good in the operating room. Why don't you come on in here and we're going to train you how to operate with us. For the last 6 years, I've been operating with them as a first assist. There's only 3,000 vascular surgeons in the United States, and probably 100 nurse practitioners that actually do what I do. So I'm very privileged to have done that and got that experience, right? In the meantime, we own a gym. And what bothered me the most, and this is our segue in how we got into wellness, is I would see people busting their ass and not getting anywhere. I don't see results. I would see it on the film, I would see the things, I would see how hard they're working. And if you told me that I was going to be an expert in women's health when I was in nurse practitioner school, I think you were crazy, right? You know, because I had all this other stuff there. And I'm like, no, I can help them, right? That's always been my thing. Everything that I've ever done is about helping people, right? That's my intrinsic motivator. I really get a lot back from that. Not accomplishments, not accolades or anything else, but really helping people is what drives me and makes me feel good. So it started with the weight loss stuff, the GLPs, right? So we started with the GLPs, and then I got signed up with the Menopause Society. Then I had educated them. We started with that. It started on the male side with andropause, with testosterone, which is very nuanced, right? All of this is very nuanced. And then we got into women's health, and then we've been in that for going on now our 4th year. So it's been very, very good, and nothing gives me more pleasure than when somebody comes up to me and like, oh my God, I feel like myself, right? I feel like where I was before, right? And thank you so much for getting me there. Now, realistic expectations, I tell people when you decide, if you decide, now answer a lot of questions that you have here today, I'm sure you have many. There's a process to that, and it's a nuance. There's not one protocol, there's guidelines. In medicine, there are guidelines of how we do things. So within those guidelines is your individual chemistry and how you react to certain things. I will say, like, a woman's standard testosterone dose is anywhere between 3.75 milligrams and 5 milligrams a week subcutaneous, minus 200. You see the difference? Right? You can't give a woman the same testosterone that you give a man. And I have many women who come to me that are on male testosterone doses from other providers that we have to adjust because they're at the low male range of labs, right? So what does it look like when you come to me and you want to talk about hormones or peptides or weight loss with me? First thing we talk about is we talk about you, what your goals are, right? What have you been through? What have you done in the past? What are you looking for? And then I explain to you what each of those things do, right? And what they look like. If it's hormones, even with men, this is kind of like the same thing. If we talk about the 3 hormones, and everybody has them in different numbers, we have testosterone, estrogen, and progesterone, right? Everybody's familiar with that. Well, Now, after I hear your story and you tell me what's going on and everything else, then I go back and we go through each single one. I say, all right, tell me about drive, motivation, brain fog, poor recovery, low libido, lack of morning erections. What, do you have any of those and stuff like that? We start talking about symptoms. Then they're like, yeah, I have this, I have that, and everything else. I already know your goals because I asked you. I have like attorneys that can range from anywhere. Like, I don't care about my libido right now. I just need to be on top of my game. I have so much brain fog. I don't need that. Or I'm not recovering anyways. I just have no energy, no drive, or motivation. This is what I want to focus on first. Or, the libido. I get anywhere from the libido. I just want the HOR and horny. I don't want the full horny till, I just want it back, right? So it's all depends on every individual person and what their goal is. And then my job as we're going through that is to pull it out of you how you're progressing. What horny looks like to you, or what recovery looks like to you, or what drive and motivation looks like to you is completely different. So I need to go ahead and pull that out of you and find out where they are, and then make sure when we have consistency in that particular, say, testosterone, is compare you that when you got to me. I'll give you a prime example. That young lady over there, right? My wife. So she, we put her on testosterone. She's gone from working out, everything else, getting down to this great body, working. She'll show you her transition. It's just remarkable from where she was to where she is now. And then she'll come to me and she'll go, I'm really tired again. I think I need a little bit more testosterone. Now, I just did her labs. I know what her labs are telling me. She doesn't need any more testosterone, right? So how do I approach that? I go, well, do you think you need a little bit more testosterone, or are you pushing a new norm, right? So it gets a chance for you to start reflecting back on yourself and what you're doing. Because yes, you're going to be tired if you push in a new norm. That's just recovery, right? So she's gone from, working out in the gym and doing everything else to now doing high rocks all over the country, right? So she's definitely pushing a new norm. And then you bring the objective data in. This is your testosterone numbers. Remember, this is where you were. So I'll tell you the range of women in free, 0.2 to 5. That's the range of free testosterone. Total testosterone, when you get a total testosterone, is what your body's using. I don't care what that number is, right? I don't care if it's a woman, it goes from 0 to 50. I don't care if it goes to 80 eventually. What we care about is that free testosterone, what's available for you to use, what you can draw on to go ahead and do the things that you want to do. And I like you in the upper quartile of the normal. So my wife got her labs, done, and the range is 0.2 to 5, right? So hers was 0.2. She's in range, right? Right? Isn't she in range?
Correct. Yeah.
Right? So if you went to somebody who's a hormone thing, oh, you're fine. She could have been 0.5 or 0.6. You're in range, right? But that's the low end of normal, right? It's barely detectable, right? So that's not normal, right? So when you look at those type of things. When we talk about the progesterone side, progesterone's all sleep. When you sleep, right? When you sit around and you talk to your girlfriends and everything else, and they tell you about looking at the ceiling at 3 o'clock in the morning or pacing and everything else like that, that's all sleep. That's all progesterone, right? So that's one of the easiest fixes that is in my toolbox. It's very nuanced. There's only 2 doses that are commercially available out there for you to get from your insurance company. 100 milligrams and 200 milligrams. I give my wife 100 milligrams, she's not getting up till noon, right? She makes her groggy. So it's individual with everybody. Usually I start people at a starter pack. I think, I want you to get to 100. I want to call that up and let these thieves of insurance companies pay for this. But if you can't tolerate it, you can't tolerate it, right? But you're going to sleep better. So my wife sleeps better on 50 when she wants to get up early in the morning, 75 when she wants to sleep in, but she can't take 100 yet. Now, maybe down the road she'll be able to take 100 as we adjust, as she goes through the transition, because she's 50, she's in that transition stage right now. So that's that. Now, the last thing, estrogen. All over the internet, right? You need estrogen, you should have estrogen, we gotta give everybody estrogen. Very true, right? Estrogen is very, very important. What is estrogen primarily related to? That we see in symptoms in perimenopause and menopause. Vasomotor symptoms, right? So, and bone health and all that other stuff, but we'll get to that, right? Vasomotor symptoms. What are vasomotor symptoms? It could be anywhere from that meme of that lady sitting on the bench, that African American lady with the bald head with steam coming all off of her head and everything else like that, to I occasionally feel warm. It comes and it goes to, I feel warm at night, I have to crank down the AC, put a fan on me. You see how I have to pull certain things out of everybody? But that's vasomotor, right? Now, how I do things with women, depending on what you want to do and depending on your age. First of all, testosterone, we have zero data for anybody over the 60 years of age with testosterone. There's no data on that, right? Doesn't mean we can't do it, but we definitely want to do a calcium CT score. We want to know how much calcium's in there. We want to think about what we want to do because there's theoretical risk that come along with that starting at over age of 60 in women on testosterone. Typically, when I start women on HRT, it's progesterone and it's testosterone. I'll tell you why in a second. First, cardinal rule. I can give you progesterone without estrogen, but I can never give you estrogen without progesterone, right? Because estrogen, if you think about your cycle, right, you're getting ready for implantation, all that growth is happening within your uterus. What prevents that from overgrowing? Progesterone, right? So that's the balance, right? We don't want, that's what you need to do. You have to balance that or you're gonna increase your risk for cancer. If you balance it, there is no risk, right? So that's why, that's the cardinal rule. Why was my poster accepted in the menopause time? Because I spoke to aromatization. What is aromatization? I'll say this twice. There is no estrogen without testosterone. There is no estrogen without testosterone. In the normal cascaded thing, testosterone metabolizes into estrogen. We call that aromatization, right? So everybody aromatizes to a certain degree. Some women, about 20% of them, are high aromatizers. She is one of them. So what do I mean by that? Is that her testosterone, she aromatizes so much that her estrogen number comes up. I don't have to replace her estrogen. Just the aromatization from the testosterone is doing that. Now, what if I just did willy-nilly and I wasn't really going on the science and I wasn't doing labs, and I put her on a patch? She'd have unopposed estrogen. Her estrogen would be so high, I wouldn't have enough progesterone here and I'd put her at risk, right? So those are the things that in the science side that we have to do with that. Now, estrogen's a big deal in men too, because you're gonna aromatize as well. And I don't know who's gonna aromatize. You heard about this on the internet. You go on testosterone, they feel good, they feel great, everything is good, and then all of a sudden they don't feel good anymore, right? That's because your estrogen went up. So then we go ahead and we put you on a modulator just to modulate your estrogen. We don't want to crush your estrogen because just like women, if I took all your estrogen away, you'd have a hot flash, right? And you'd be mad at me, right? So that's not it. But back to women, I usually start on progesterone, right? And then I start them on testosterone. And then I want to see how your hot flashes improve. If you're in perimenopause, you're like this with your hormones. This is what it's doing. Everybody's telling you, it used to be, we don't take labs because you're like this. This is the way you are. Well, that's not really true, right? We need labs because it gives us a baseline of where you're at. And number two, as we move on, I need to know what a therapeutic level that I'm getting your estrogen in. So you have proper bone health, you don't have a hip fracture, and then, you know, with many people, I've seen it, a hip fracture is a life sentence, right? It's over, right? They don't come back from that. So you need to have good bone health. So I go ahead and I look at that, see how your hormones are going in perimenopause, see how your vasomotor symptoms, because if you're aromatizing a little bit more of this estrogen, then when you go in that little trough of your estrogen, it's gonna bring that number up a little bit higher. And if your vasomotor symptoms improve, I don't have to do anything at that particular point, right? Until your estrogen comes down lower later on. So the average age of menopause is 52 years of age. So if you're, you know, perimenopause starts 10 to 15 years prior to that. So if you're in that age, congratulations, you're in perimenopause, right? So that's just the numbers. Where am I going to go from that?
Go for the over 60 post-menopause most likely.
Over 60 post-menopause. I need to have an estradiol level greater than 60. That's the minimum threshold that you should have for proper bone health. And it should be anywhere between 100 and 200, right? So you have to adjust the patch on that particular thing. And remember, you have to have the progesterone. Now you say, hey, I sleep great. That's wonderful. Let's give you some progesterone. That's, you know, that can help you out. But I ask additional questions about your sleep. The first thing I ask you, are you dreaming? Why do you think I'm asking, why are you dreaming? REM sleep, right? Because you could be sleeping okay, but you're not in REM. And where do you recover? REM, right? So, and where do you dream? REM. right? So if you're telling me I'm not dreaming, I don't remember my last dream, but I sleep good, that's not really good sleep, right? That's just by you telling me that right now. So that's another reason why I put you on progesterone. But over 60 is typically estrogen patch, micronized progesterone, standard of care. This is what you do. It should not break the bank. You have a couple of options out there. I like doing the patch, and I like doing the micronized progesterone. That's your lowest risk. There is basically zero risk with that therapy, according to all the studies. You could go with the oral, like Bijuva or something like that. That's a combination of progesterone and estrogen through a pill. Your risk goes up a little bit more, but not that much, right? It's not that great. It's not like it used to be. It's a little harder for me to dial you in with a pill because of first pass metabolism. What's first pass metabolism? All these fancy things. My wife told me not to do all these fancy words with you today. Anytime you take a pill, right, and it gets processed, it goes through the liver. Once it goes through the liver, it takes a big chunk of that effectiveness of that pill away. So if you're on Bijuva, you're only getting 40% of that 1 milligram. It's a little bit harder where you're going to get much more transdermal, right? That's all the studies that we've gone into. Testosterone, I'm not against giving testosterone to women over 60, but I want a calcium CT, right? Anybody know what a calcium CT is? Calcium CT it measures the amount of calcium that's in your heart. It's a 30-second exam. Insurance does not pay for it, right? You go to a local imaging center, you pay your $95, and you get your scan, right? If you're usually the score is from 0 to 400. Anything 200 and above, you need to go see a cardiologist because you got heavy plaque, right? And that's something you need to look at first. And once they clear you, then you can go on the testosterone, and it's a very low and slow. If you're 0, you're not dying of a heart attack, right? And familial history is important, and I'll give you an example. My biological father died at 48 years of age of a heart attack, right? So I should have plaque in my heart, right? I have familial history. It's definitely significant. He was an alcoholic, right? He smoked cigarettes. He didn't work out. I mean, all those type of things, and I've been an athlete all my life. My calcium score was 0, right? So lifestyle is really, really important in all of this, right? If you were a former smoker, or if you didn't eat well before, and now your lifestyle's here, you probably have some plaque. I will tell you that most of the people I've operated on in vascular surgery, former smokers, are the ones with the most plaque, right? That's just the way it is. But as far as over 60, I'm not against starting testosterone, but I think we work you up and we make sure that it's going to be safe, and then we discuss the risk, and then we go low and slow, right? We start you off really low, and we build you up, because you might not need as much. So typically I start women at 3.75, I might start you at 2.5, depending on what your labs are, right? So more than likely, you're not gonna have a lot of testosterone. Lastly, I wanna go into this before I go ahead and forget about it, is what a lot of primary care physicians or providers do with women who come in who are complaining that they have depression, anxiety, and everything else when they are on perimenopause and menopause. What do they typically want to offer you? Antidepressants, right? I cannot tell you how many people I've gotten off of antidepressants, right? And it's a range from, I have a 26-year-old guy who was in Fallujah with the Marines during that bad time over there. Came back, has a testosterone, like the range from men's 300 to 1200. Comes back with a testosterone of 312. Doesn't hit the criteria of less than 300. VA says, I'm not gonna put you on testosterone replacement, on a whole bunch of antidepressants, anxiety, everything else. I put him on TRTs off all those meds. A lot of women have come and, I have a lot of anxiety, especially just before my period. I was never like that before. I don't know what's wrong with me. I want to crawl out of my skin. They put me on this antidepressant. I hated this thing. It doesn't make me feel good. I'm not myself. Go to modern hormones, they're off all their antidepressants, right? Because they don't have those symptoms anymore. I had those symptoms. You could ask my wife. I would walk into Home Depot prior to going on testosterone replacement therapy, and out of nowhere, the backup alarm's going beep, beep, beep. I was like, oh, like I want to crawl out of my skin with like anxiety and everything else. I don't know where it came from. I don't know what it was. There was a freaking backup alarm. You know, I don't know what triggered it. And I'd come out and I'd call her, and must be my PTSD, right? Because nobody gets out of what I've done in my career without a little bit of PTSD, right? So I'm like, must be my PTSD, it was my hormones. Ever since I've been on TRT, I've not had one more anxiety attack like that since then, right? So that's another thing that's very, very important. Now, does that mean everybody can come off their medicines? No. Does that mean I take you off your medicines? No. I work in cohort with your therapist, right? You tell your therapist about this, you feel better, you ask your therapist, hey, can I go ahead and you think I can start coming off of this? Can you dial me down? Let's look at my symptoms. And you gradually come off those medications. Those medications are not a cold turkey come off type of medications. That's something that you have to work with everybody, and you have to try to achieve that goal, right? So I work with a lot of other providers. They're welcome to call me and everything else.
I'm going to steer you a little bit. I'm going to tell a quick story because I think it's probably pertinent, and I'm going to share a little bit of my personal story with him. So when we first started together, since I was 35, I've been on cholesterol meds. Just genetically, that was going to happen, and we made a group decision, which is something that many of you might be very interested in. Like, we actually have a discussion. I have never had a conference call with him less than 45 minutes, just because he's going to give you the time. And if you've ever felt rushed out of your OB/GYN's office or your doctor's office, that is not going to happen with someone like him. I'm not saying it has to be him, but you need to find somebody when it comes to this stuff who will discuss it with you. But we said, hey, let's give it a shot. Let's lower your dose. We lowered my dose of the cholesterol meds because I've been on them quite a long time at the exact same dosage for a long time. Got the second set of labs, he's like, yeah, you're going back on. So if you got to go back on, you got to go back, and he does that. But where I'd like to steer you next, Scott, is that I'm looking at the people here and the people who will be watching this at home. Tara knows this. The average person joins a gym, I've told you guys this story, and goes about 2.7 times a week. That's like, it's not very much. The average person here goes about 4.9 times a week. So most of our people go between 3 and 5 days a week. So one of the things I'd like you to steer the discussion before we open it up for questions is recovery. Because they come in and they work out hard 3, 4, 5 days a week. What can you help them, or what can a person of your caliber of education help them to do to recover better from the intensities they're putting into their workouts, especially knowing that Tara works out at the level she has?
That's a really, really good question. And what does recovery look like? I have some clients who come in, I work out 7 days a week. This is what I'm doing. I love it. I'm in the gym. This is where I find peace. You can't take that away from me. Initially, you can't, right? You're not going to switch them up on that. But when you start getting to a point where they start feeling better and they're recovering, you have to talk about what their goal is, right? Goals are very, very important. Why are you in the gym 7 days a week? What is your goal? What are you trying to obtain when you're getting to that? And refocus a person back on what their ultimate goal is. There's other ways to stay occupied, right? You don't have to be in the gym 7 days a week to where you can't recover because you're not giving yourself a rest period, right? So that's part of the whole psychological thing about health, right? When we get to a certain degree, you're feeling better, you're overtraining. You cannot make the gains that you want to make when you overtrain. We go to the Olympia every single year, right? We see the most premier bodybuilders in the world. We sit there and we talk to them, we ask them what they do. They all have recovery days, right? All of them have that, right? So it's one of those things, a good learning lesson for us. So then I come back and I start coaching you a little bit on your diet, right? Nobody wants to hear about diet when they want to lose weight, want to get everything. There have been 1,000 diets and everything else, but you give them one goal. One. You need to consume 100 grams of protein a day. That's your goal, right? If you start consuming 100 grams of protein a day, there's not a lot of room for carbs and fats. You're going to figure that out really quickly. Then, once you get to 100 grams of protein and you're getting your goals and you're looking good, now I step it up. Ideally, remember I told you 100 grams of protein? It's really 1 gram of protein per pound of desired body weight. So your body weight, if you want to be 140, you got to consume 140. So now you need to step it up from 100 to 140. Now, you're willing to do that at that point because you've seen gains, you feel good, you're recovering better. And then you're going to say, hey, you're overtraining. I'm telling you, that leads to injury. You're going to get hurt. And then all these things and all these advances that you've gotten that you want to make, are going to go down the tube because now you're not going to be able to do it and you're going to be even more frustrated. That leads to depression. Find something else to do. Go walking. Go play pickleball. Go do something else that's going to go ahead and fill that, but doesn't need to be in the gym. Doesn't mean that you can still be active, but you can still do it.
I am. I dressed up as a pickleball player for Halloween.
Oh my God.
See, it's stuck in my head.
So I'm really glad you touched on that. One more thing I'm going to steer is before I let you guys, because I know many of you guys and gals in here might have some questions. Just if you could just talk about how your process and what anybody who is educated. So this way you also know how to run away from the person who's talking to you and they're not talking the right language. That this is a process. You've heard this from me about fat loss, but I also want to talk about it with HRT. If you need to lose 40 or 50 pounds, not you people here, but I can't do that in 2 weeks. I can't do it in a month. This is a process. If you decide to jump into some hormone replacement therapy, either with Scott or with somebody else, you can't do one set of lab tests and think that you've got your answers. I want you to just touch on that a little bit.
So what does it look like with me? So I spent a lot of time sitting here right now, probably 20, 30 minutes already talking to you about like Hurricane, what it did, but I spend 20 to 30 minutes on an initial consultation that I do not charge you for. Right? And I ask you about you. Then I go ahead and I tell you what I can do for you. Typically, and it's labs. It always starts with labs, right? It does two things for us. Number one, it gives you a moment to really think about what I educated you on, about what the road looks like in the future. So if you told me I'm not sleeping good, everything else like this, I have hot flashes, great. We're talking about micronized progesterone and a patch. I have my own protocol for a patch. I'll tell you, that when you ask me a little bit later. Make sure you ask me about the patch a little bit later, okay? And then, it gives us time, and it gives you time to think about what I went ahead and told you. We get the data back. You gave me your subjective information. Now I have objective information, and I look at that data, and I look at our note and what we talked about. I put a comprehensive review, written comprehensive review about you. Not a format that's like this pre-formatted note. I dictate, you can ask my wife, I sit there and dictate every single note. I look at your labs, I have my other note on the screens, I have 3 screens on my computer system, and I go ahead and I look at everything and I dictate your note, and your note comes out, and then I go back and I edit it and I send you a comprehensive review along with that Chinese that you get back from the lab, right? That's really, that you can't read. Then we meet again. It takes about 30 minutes for us to meet again because now I'm going to teach you about what I see in your labs and how it relates to you and the things that we look out for labs. You do not need a doctorate degree to read labs. You need somebody just to point out why these labs are important and what are we looking at, right? That's what you need to go ahead and do. So why is that important for me? It's important to me that if you leave me, or you would never even go with me, then you're able to advocate for yourself when you go forward, right? It's like Bobby told you go into another OBGYN, I don't need to do labs. You know how many people I got to say, I don't need to do follow-up labs, have to get hormones? And that's why they came to me, because their providers weren't doing follow-up labs, right? So that's, red flags. You start learning what these red flags are, and you can advocate for yourself, and don't be afraid to find another provider. That means they don't really have the time for you. When I was at the Menopause Society, OBGYNs, the professional ones at the Menopause Society, they have 2 different office visits. There's a woman's wellness visit to check you out, to make sure everything you're going good, and then there's a hormone visit, 2 different visits. You cannot have that discussion in the same time because they're 2 lengthy conversations and they're 2 individual discussions, right? Mine are an individual discussion with you. We spend a lot of time before we even prescribe that first piece of medicine, right? Now, like GLPs, you can go on them earlier if you wanted to lose weight. I don't really need a full set of labs from that to get you going on a GLP, but hormones, you have to do it. Here's my standard of how I do things with hormones. We start you on a hormone, it's a repeat lab panel in 3 months. If we change something or adjust medication anytime, it's a repeat lab in 3 months. I need the objective data to make sure that we're getting you in the direction that we need to get you for your overall well-being. Once we get you stabilized, that's 6 months right there, right? That's 6 months. Once we get you stabilized, or you're feeling great, and I don't have to adjust anything, it's labs every 6 months because things change, right? And then I want to hear from you. You know, you're gonna go, I'm on my way, everything's good. You know, I don't want to hear from you just when you want to refill. I want to hear from you in 6 months and work you up and then say, hey, my first question when I get back on, hey, how are you doing? How are you feeling? That's my very first question, right? Well, I'm doing this, I'm that, and everything else, and I listen. I don't have to write my note, I don't have to do anything, I listen. And people go on about what they're feeling, and that leads me to ask further questions, right? You know, my hot flashes are not as bad as they used to, they're so much better. Well, they're not gone, right? So we still have work to do, right? You know, so then I have to look at the labs and see where you are and adjust to get you where you want to go. That's so, and additionally, the last thing, what makes me different than everybody else? And this is my commitment to you. You can ask Bobby every time, not because he's Bobby, not because he knows my wife, not because anything like that. You get my telephone number, my direct number. I encourage you to text me when you have questions. I encourage you to check in with me. Anyone that's my patient, I tell them, they'll tell you, he answers you right away, right? Unless I'm doing something where I can't, I will get back to you within hours, but I answer you right away. If it's longer than 2 sentences in a text message, I'll probably call you, right? Because I need to explain it to you, right? And we need to talk it out, and or I'm not really getting the full context of what you're asking here, and I probably need a little deeper insight, but I will call you. That's my commitment to you, and that's what makes me different than anybody else. You don't have all your other doctors' telephone numbers, do you? Right? So that's what my service is different than everybody else. And I really take pride in that. Now, you text me at 11 o'clock at night, I may not answer you unless I'm up watching a game. Like I did answer somebody the other night when I was watching UM in the championship game, right? So I was up and they were shocked that I answered them at 11 o'clock at night, right? I said, well, I'm up, so I might as well answer you. Typically what happens, I don't care if you text me at 1 o'clock in the morning. My phone goes on silent. It's already, you know, it has that feature in it, right? I go to sleep, I wake up in the morning, I have my coffee, and I answer my text messages, right? That begins my day. I don't start my office till 9:30 in the morning because I have clients to talk to, right? I'm gonna be talking to clients in the morning. They're gonna call me, I need refills, I need these other things. I have to get things, before I even sit down, I have my first appointment a day at 9:30 in the morning. You know, so I make time for that in my schedule. And really, how hard is it? You know, I'm at dinner, we were at dinner the other night. I sit down, somebody texts me, I answer back, okay, you're doing great, everything else, adjust your dose to this week, please check in with me again next week. That's a text message. Now, we're all adults in this room, right? I have a lot of patients. I cannot go and follow up with all of my patients individually, right? I don't have the time, but those who go ahead and text me, I will answer you and I will engage with you, right? So it's kind of like a two-way street. You do not bother me. This is my business, what I chose to go into, right? So it's not a bother to me. In fact, I told you, what's my intrinsic motivator? My intrinsic motivator is to help people, right? To make them feel better. That's where I feel better. That's where I feel successful, right? So if you text me, I will text you back. If you go and say, I don't want to text him because I don't want to bother him, that's not me, that's you, right? I'm telling you, you have permission to bother me, right? I don't mind, right? Now, if we're gonna have long conversations, then, you know, we'll talk about that, but, you know, otherwise than that, I'm an open book.
So, I wanted him to give a general overview. I think we've done that. I want to give you an opportunity to ask questions, but I'm going to give you some criteria. A, we're not going to hear your whole health history while we do this so that he diagnoses you right here in front of everybody. This is going to be a little bit more generalization questions. I will allow him to stay 15 minutes longer. If you personally have a question you want to talk to him about in private, that's fine too, but we're not going to turn this into a 5-hour office visit. He has a life. Does anybody have any general questions that we can do for the next, say, like 15 minutes, and then I'm going to let him just wrap up for 5 minutes, and then we'll make him available to you after that. Does anybody have any general questions that maybe you've always wanted to know about hormones or supplements? Because he will, you know, he's also made sure that I changed multivitamins, and I changed the different vitamin D that I was using. Mindy, why don't you start?
Okay, I think you may have mentioned this, but so I'm 47, and I was told, because I'm in that perimenopause state, my hormones like this, it's like I can take labs this day, or I can take labs this day, or I can take labs this day, and depending on what day I'm at, my labs could be all over the place, so how does that give you data that's reliable depending on the day or time I do the labs?
Right, I did allude to that a little bit. There's only two that are gonna be that way on your labs, progesterone and estrogen. That's it. Testosterone is gonna come back the number it is. On top of that, all of your other markers are gonna come back the way they are. Your thyroid, what's going on with your thyroid? What's going on with your complete blood count? What's going on with your liver? What's going on with your kidneys? What's going on with your cholesterol, right? I look at your whole cholesterol. Let me tell you something about cholesterol and what medicine does. All hormones are derived from cholesterol. Did you know that? All hormones. So what happens, you think, when you're not making any hormones? What is your body going to do? Make some more cholesterol. Say, yo, you need to make some hormones. And I'm like, I ain't making any hormones. And what does medicine do? Puts you on a statin, right? And we don't fix this. Most people I put you on a hormone, all these things come back down to normal. They all play down to normal. Within that, HDL, right? You got your LDL's bad cholesterol, HDL's good cholesterol, right? You know, HDL is very, very good. You need to maintain your HDL, or if it's not where it's supposed to be, it should be. What's that? That's fish oils, or cooking with oils, or doing stuff like those type of things. That's very, very important. We want to make sure your HDL stays as high as it possibly can, right? That you're taking a good quality fish oil. I had a client like, dude, I've been on these fish oils for like 6 months. His HDL is 30, should be above 60. I go, it's garbage. Your product's garbage. It's not working, right? Because he switches it, comes back, does the lab, he's above 60. There's your objective data, right? So we look at more than just that. Secondly, you're going to make that transition somewhere around 52, right? So even though that numbers were like that, what if I catch it at the high end? What if I catch it at the high end and your number's 30 and you're having vasomotor symptoms, right? You know, well, we know at some point, as you make that transition, as I put you on medicine to take care of your symptoms, I'm gonna keep looking at that number, because that number is gonna stabilize eventually, right? And then I need to get you in a therapeutic range so you don't get a hip fracture later on. So it's a whole process, not just the progesterone and estrogen. Yes, I may get a dip at that particular point. Yes, it may not be completely effective. But if I put you on therapy, that dip is not gonna be what it was before. Just logically, right? Say your dip was 10 on estrogen, and I put you on a patch. That dip's never gonna stay at 10. If I catch you at another dip, it's gonna be 40, right? It's going to go up. It's never gonna be that low again. So we already know you're making progress. What's that? Same thing with your progesterone. Most women that come back to sleep issues, their progesterone's non-detectable. Low end, non-detectable, you're not sleeping, I know it's your progesterone. Then it comes back at 2. You made progress, right? Right? Is that your high end? No, because you weren't making any in the beginning, right? It was undetectable.
What about for her specifically, the timing? Isn't it day 19?
Right, the other thing is the timing. You have to go ahead and do it in the luteal phase of your cycle, right? So that's between the 18th and 22nd day of your cycle for me to get a proper reading on your hormones. You can do it for any day on your testosterone, but for that particular part, I get the best reading during that stage of your cycle. Now, a lot of people have ablations, they have hysterectomies, they've had these other things, they don't have a cycle anymore. Well, we try to estimate it because you kind of know when your symptoms come on, right? You know, the anxiety or these things, or you know when you feel like you're ovulating still, right? You know, you can do it by your temperature, you can do these things, so we try to get as close to that as possible. But you're absolutely right, it's only progesterone and estrogen, but we treat symptoms, and once we treat you, those numbers are gonna come up, and it's gonna give us an objective data anyways. That used to be the way they did it at the Menopause Society, and when I was there the last time, that whole thing's changed, and yeah, we gotta do labs. Yes, we gotta do labs. So that whole thought process in the past is going out the window, and regular labs are going to be the standard of care going forward.
And the way I'll answer that too is that if you've never been with a doctor who's done it like this before, he's very specific on, obviously you've heard, you know, fasted and do things in the morning. We all have heard that. But it's like, hey, when you take your testosterone shot, I want you to wait 3 days and we're gonna do this. Or I want you to wait 5, like he's gonna be very specific of like, you have to do it now because it's gonna be consistent with how we did it last time. So there is a process. It's gonna be different for all of you, but there is a process, and that was a really good question. Yes, Jazz?
So, if I'm already on hormone therapy replacements, and they still tell me that I'm vitamin D deficient and chronic inflammation, and taking different supplements, how do you know what's garbage versus not garbage, and which is the things to take?
So I use Metagenics. It's a little bit more expensive. I've been using Metagenics for like 20 years, their product. What's the other one? The Thorn. Thorn is supposed to be very, very good as well. Reputable products. Vitamin D, let me just back up on vitamin D. Why do you think vitamin D is so important? Anybody?
Bones.
Partially. Vitamin D is a hormone. Not only is it, you can look it up on Google Scholar and look up vitamin D, it's related to all-cause mortality. Cancer, Alzheimer's, everything else like that. Your vitamin D should be above 50. Most people are down around 30 or 20. In women and in men, when you start going on your hormone replacement, aha moment in menopause society for me this year. Directly relates to how you metabolize your estrogen. You have 3 estrogens, E1, E2, E3. We typically only test for E2, but you metabolize all of it. So it's counterproductive for you if you're going on hormone therapy and your vitamin D is tanked because you're not optimized, right? Your vitamin D has to be above 50 in order to metabolize your estrogen properly. And even that, just that subtle little thing about, hey, you need to be on the better product. I know you've been using this product for 3 months and it hasn't gone up. It's garbage. You need to switch it. You need to spend a little bit more money, get a good product. Let's do our labs. And then when your labs come back and they're above 50, you're like, oh, this guy was right. You know, it's about the product. It's about what you, and there's so many bites. Tara was telling me the other day that, you know, she's getting all over her feed and everything else, you know. Hey, are you overweight? Are you doing this? How's things going? You know, do you want to lose this? How's your hormones? We got this all-in-one pill for African American females that you can take that takes care of it all. I don't know how you do that. You know, I'd be out of business if you did that. You know, there's, you know, what are you taking? How much you taking? What's in that pill? And then it says proprietary brand, right? Which means we ain't telling you. We're not going to tell you what's in it, right? So if you don't know what you're taking, don't take it, right? So with you, you know, like you said, you're thinking you're already on hormone therapy. It's about getting your symptoms, and once your symptoms are under control and where you are, getting your micronutrients up to where you have to be. Then we talk about the long-term health, what your goals are, and make sure you get there. So as we get to the transition stage, you're getting to that above 60, more to 100. You don't have to worry about it. You feel good. You're on the same thing. Now it's just cruise control. You're cruise control for the rest of your life. But that dial-in period can take anywhere between 6 months and a year to get you dialed in, right, with labs.
What about the patch?
Patch, you talked to me about the patch before I get to you, right? So this is what I found out about the patch. This is what you learn when you get into hormone therapy, specifically with women in an estrogen patch. The guidance is twice a weekly patch or once a week patch. We tried once a week patch, they're garbage, they fall off, they don't work very well. They're not really good, they're not real well manufactured. The bi-weekly patches are excellent. They'll stick on you and they're not coming off, they're great. It's a patch you put on your hip or your butt, somewhere around here, and you switch up. Now, if I put you on a patch right from the beginning, twice a week, you're gonna retain water, you're gonna bloat, and you're gonna get pissed at me, right? You know, and you're gonna be non-compliant.
Tell them why.
Huh? Right?
Because she got pissed at.
I was mad.
He had to sleep next to her.
And I got a lot of phone calls. Well, you didn't get your low estrogen overnight, did you? Is there any rush to go ahead and introduce this estrogen? Do we have to do it like right away in the first 2 weeks? So what I learned, and I developed a new protocol, is 1 patch a week for 4 weeks, slowly introduce the estrogen, then 1 patch every 5 days for 2 weeks, then we finally go to 2 patches a week. So we're slowly introducing that estrogen. It does 2 things. Number 1, you don't bloat, you're not pissed at me, and I have compliance, and we build trust, right? So all that's very important. Remember, it's important to me that you feel good. And when I got those phone calls, I'm not taking this garbage, I bloated and everything else, my belly's out to here, there's no way going. I get that with progesterone too. Progesterone will make you bloat a little bit as well when you initially start, but give it 2 weeks and then that goes away. Your question?
Do you recommend injectable testosterone for women or to use the cream?
Excellent question. Excellent question. So, for men and women, there are 3 administration methods for you to go ahead and take testosterone. There's the cream, right? You put it underneath your arms, inside of your legs. On males, you can wipe it on your testicles, you know, and you could do the cream. Problem with cream is that if you have small animals, small kids, or anything else like that, you can transfer that cream to them, and you have to be careful about that. Secondly, you got to remember to put it on every single night. And some people, like my wife, started in cream. She's like, I don't want to inject myself with a needle. I don't want to be a bodybuilder. I don't want to do this. This is not what I want to do. I want to start with a cream. After about 3 months, she was like, did I put it on last night? Did I not put it on last night? This is getting to be a pain in the neck. Cream only gets you halfway there. It's never going to get you in the upper quartile of normal. It's just not going to get you there. Little caveat to cream. If you ever go to anybody and they want to put you on everything all at once, you need to run as fast as you can. Right? You should not be put on testosterone, estrogen, progesterone all at once. Right? Most of the people I saw that got those type of creams that put them on there, first of all, progesterone does not get absorbed into the skin practically at all. It's just basically useless. They're in the hospital with migraines. I've had 4 people that come to me afterwards after somebody prescribed them that type of administration. So the second one is pellets. We all heard about pellets, right? These first 2 are basically for people that are needle adverse. People that don't want to inject themselves. I have yet to have one person not be able to inject themselves. The needle is so small. It's the fact of injecting yourself the first time is worse than actually injecting yourself, right? You'll figure that out quickly. And I do it over FaceTime. I'm gonna teach you how to do it. They do it, and they're like, that was it? That was it. Next one's pellets. Problem with pellets is it's like a bell curve. First 6 weeks you feel really great, then you start trailing off. Typically what happens when you get towards that last part of the stage right here, you go back into your pellet person, the pellet person say, hey, I feel like shit again. They put the pellet in early, they keep you super therapeutic, right? Our goal is not to make you super therapeutic. It's called testosterone replacement therapy, upper quartile of normal, right? So remember I told you the range is 0.2 to 5 for free testosterone? When I get women come to me and I do their labs after they've been on pellets and they're at the bottom of their peak, they're coming off their peak, they have a free T of like 20. Right? If you stay at super therapeutic level, you risk virilization over a long period of time. What's virilization? Virilization is male-like qualities. You get hair growing out somewhere else, you get more pimples, you can end up affecting your voice over the long period of time. I've had women with clitoral enlargement. You know, a lot of those things happen with that. Not everybody happens, but it's possible when you're at that point. And lastly is the injectables. You could do with men, you could do it 2 different ways too, right? So men can do sub-Q if you do it every single day. Monday through Friday, you have to go ahead and inject yourself with testosterone if you want to do it with a small little needle. That is by far, my clients who are anal like that stick themselves with a needle every single day and they do it, have the most pristine labs out of all my clients. It mimics the normal production of your testosterone, right? If you could do that, God bless you, I'm not doing that. I inject myself twice a week, I ain't got time to check myself every single day, right? Women, it's sub-Q once a week. That's it. In your belly, once a week, you rub it real good, next week you switch it over to the other side. That's it, right? It's very, very simple. You do it once a week, you know your Fridays or whatever day you do it on. You can do it night, daytime, whatever. Thing about testosterone, it's not like you have to be so anal that it's like Friday at 6 o'clock. There's a lot of times we're busy, we miss our dose, we don't do it till the next day. We did our dose of testosterone, our normal dose of testosterone is on Friday. We traveled on Friday, we did it Thursday night. Right? So you can adjust that with testosterone going forward. Men who inject themselves once a week or twice a week, it's IM, right? It's intermuscular, right? So I've done a lot of research on the needles. I typically bring in the supplies of the needles. They're very, they don't hurt. They're good. One needle to draw up the medicine, one needle to inject. So that's how you go ahead and do that. But I prescribe injectable testosterone. Now, how long does that last?
Yeah, so are you using like 100 milligram per ml and using an insulin syringe to get the
Great question, but you have good questions. So they come in 2 doses. 200 milligrams per ml is a male dose. That's a male concentration. When I prescribe women, it's 25 milligrams per ml. See the difference? Right? Because you can't draw up the same volume. You can't get 3.75 milligrams from 200 milligrams per ml. You can't really get that small amount in a syringe. So you need to have the proper dose for a woman. It's 25 milligrams per ml, right? So that's what you get when I prescribe it for you. It's a woman's dose. It's made for a woman, and that's the dose that you get. Now, sometimes I've probably had maybe 5% of women get a localized reaction with the oil that particular one comes in. If that happens, I just call the pharmacy, no charge. I change the ester, the oil, and I give you a new oil. You can throw the other one away, and then that allergic reaction stops.
Are you using a compounded, like
Yes.
a 503B pharmacy to do that?
Excuse me?
You're using a compounded. So
Compounded.
you're not- because commercially it's only 100 or 200.
Right. I'm using a compounded one, yes. But I use it, let's go to compound. You can go across the street over there, there could be a compound pharmacy, right? I don't use that pharmacy. There's only a few FDA-approved sterile compound pharmacies, right? Where they're underneath certain guidelines from the state and everything else. They have all the hoods and the sheds and they do these things. I only get my product from sterile compound pharmacy. That's it. I don't use these little compound pharmacies or anything else. Give a reputable one. And I've not had a major adverse reaction from any of the products that I've prescribed from that pharmacy, because when I did my research, when I started my practice, that's a big deal. I work in surgery. I operate on abscesses, right? And I know how bad they are. And you need clean product, and you should have clean product for people, because I don't want that to happen to any of my patients, right? So when I did my research, I made sure that I went ahead and vetted out the proper place to get the medication. I need to know that what I'm prescribing you is actually what you're getting. That's important.
Why don't we do this? Why don't you just do a quick little wrap up, or, just on how you want to do that, and then anybody who doesn't have questions or whatever, you guys, thank you for coming. But like the people who have like some more specific stuff, we'll have them stick around.
I know we don't want to keep them here all morning.
Right.
We're
Yeah,
not in a
I knew
rush.
they weren't going to rush out the door. So I know some of your questions are going to be very specific to you, and I want to give you an opportunity to do that. You might have to stick around for 15, 20 minutes until your turn. But why don't you just kind of wrap up the talk in general?
All right, so to wrap up the talk to the general, I'm going to wrap up like I started. I'm not here to sell you anything. I was here to educate you today. I really enjoy you having me out here. Thank you so much. I think it's important that if you're thinking about going down the road to do hormone therapy, you do your own homework too, right? The Menopause Society, one of the first lectures they gave up, it's a collaborative relationship. And I believe in that, right? It really should be a two-way street. If you have questions, you don't like that way to go, don't do it, right? If you don't like to hear what your doctor is telling you, and you might have been with them for 20 years, go find a new doctor, right? You can have multiple doctors. You can have the one doctor that takes care of your health, that's very, very good, that doesn't do hormones. Like, I don't have time for hormones, I'm not doing hormones, I'm not gonna do it. And then you go find somebody else who's going to go ahead and do this for you. You wanna make sure that if you're going to do it, or you're gonna do an online system, they don't ghost you, right? That's very, very important, that you're gonna get the kind of care that you're looking for. And lastly, it should never break the bank. Ever, hormone replacement therapy should not break the bank. I think my average cost might be, $100 a month for testosterone. That doesn't break the bank. And that includes access to me and to manage you, right? So that's not very, very expensive for hormone replacement. If you just went on, a woman just wanted to go on patches and progesterone, I charge you a yearly fee of $250 to manage you, and you call all your stuff into your pharmacy. That's nothing, right? That's really not very expensive. If you go to people and they're going to charge you, hey, just to see me is $4,000, and then we'll decide what we're going to do for you. You heard about those things, right? That's just criminal to me, right? That's not really good medicine, and that's not helping people, right? There's plenty of money around and everything else, and people are not going to leave you. I have people from day one still with me, right? They're very, very happy, and they probably going to be with me for the rest of their life, and that's great for me because it's easy to manage, because I remember where we started and where you're going, right? So I can adjust and go forward from that. But it was really cool seeing all of you out here to come out here and see me. I mean, it makes my heart full. I really appreciate it. And we'll stand around now. What we'll do for you after this, if you want to make an appointment with me, I'll let you do this. This is the last thing I'm going to tell you about what my cost is and what you can do for me today if you wanted to. Everything starts with labs, right? If you have health insurance, I use your health insurance through Quest. They pay for the labs. My cost to do everything for your initial read, to tell you what I think about you and where you are in your health, is $175. Remember that, like 2 hours worth of stuff that we have to do? That's my charge for you. My assistant Lisa will go ahead and send it to you. Like Tara has a link. You can go to Tara, she'll get your telephone number, she'll send you the link. I've opened up my whole appointment schedule to midnight tonight. You make an appointment tonight, we're not seeing you today, right? You're just making an appointment so my assistant Lisa can send you the forms to finish your chart, and then we'll go ahead and send you your labs, charge your card $175, and then we will meet online again once your labs come in, if you want to do that, right? So that's what we'll be willing to do for you today. If you want to step back and think about it, then that's what you should do, right? I truly believe that. And remember, I'm not starting you on anything today. The one thing we didn't talk about, if anybody wants to talk to me on the side, which is a little bit lengthier conversation, is the weight loss management stuff. A lot of women like microdosing that. They really do. They get great results out of microdosing GLPs. Super, super good. I've used it in women as young as 18. Women that have that moon face and they're athletes and they have this puffiness and they've gone all to their doctors. We put them on microdoses and they look like normal kids again, right? And most women, when they get that puffiness, they can't get that puffiness off. They go on a microdose of the GLP and they look great. They look fantastic. But thank you so much for coming to see me today. I really appreciate that.
Thank you.
One of the things I'm going to say before the people who need to go leave and the people who want to stay and ask questions can do that. One of the things I love when we had a discussion, and I didn't want to bring it up here because I think our discussion was almost 45 minutes long just about this. You're reading a lot more about peptides. You're hearing a lot more about peptides. And the reality of it is that the research is still a little bit dicey on that. And just because it could make him money, or just because he has a client who says, I want to go on this, he's going to go, I'm not doing that because the research does not support what you're hearing and reading in the magazines or whatever. So just know you've all known this about me for as long as you've known me. I'm a very research-based person. He puts me to shame. I mean, I don't know have any idea how much time he has to read all the stuff
It's
he
a
reads.
lot.
So, thank you for coming. I will have this video available. Give me a little time to get it done, but whatever. And if you want to come up and talk to him, please do so. Enjoy the rest of your Saturday.
Thank you.
Thank you.